first topic is going to be presented by Dr. Melanie Miller, one of our R1s, oxygen supplementation in acutely ill patients. How much is too much? Dr. Miller.
Good afternoon, everyone, and thanks, Dr. Freed, for that introduction. So I think this topic comes up a lot within the ICU and kind of outside of the ICU. So we wanted to explore it further and see kind of what the current recommendations are. So our myth is in acutely ill patients, targeting an SpO2 saturation of greater than 96% is harmless. So the goals of this discussion. So we're going to start first by just reviewing hypoxemia and hypoxia and the definitions of those, and then go on to hyperoxia and its detrimental effects. From there, we'll review oxygen supplementation in both MI and stroke and some literature in both those conditions. Then we'll finish up with oxygen supplementation in basically every other type of patient population. And go over current recommendations. What we're not going to do today is discuss oxygen goals in patients who are hypercapnic or CO2 retainers. I think this has been well established that the oxygen goals for those patients are 88 to 92%. So as residents, we are extremely lucky to be privy to Dr. Freed's lectures on hypoxemia and hypoxia. So just as a refresher for all of us in the room, hypoxemia is defined as low dissolved partial pressure of O2 in the blood, or PaO2. Hypoxia is defined as oxygen deficiency at the tissue level. So this could be either delivery of oxygen or impairment of oxygen absorption at the tissue level. So the delivery of oxygen is based on cardiac output, which is heart rate times stroke volume, and then the carrying capacity of O2 of the blood. And so the two kind of terms that are most important in the carrying capacity are the concentration of hemoglobin and the amount of saturation of hemoglobin, plus this small term of the actual dissolved partial pressure times 0.003. And just as a reminder for all of us, PaO2 of 60 correlates to approximately a SpO2 of about 90%. And this is something I think we all remember because it's at this point in the curve that patients are kind of at risk of becoming more hypoxic and kind of hitting that more steep part of the oxygen dissociation curve. And one thing I'd really like to point out, so when patients are on an FiO2 of 21% or room air, and we maximally increase this to 100% and FiO2 of 1, we're really minimally increasing this term here. Maybe we're going from 93 to 100%, where we could maximally increase this term here. So we could go from a PaO2 of 80 or 100 to a PaO2 of 600. So moving on to hyperoxia. So hyperoxia has demonstrated detrimental effects. In terms of its vascular effects, it's known to cause vasoconstriction, particularly coronary vasoconstriction and cerebral vasoconstriction. There's also associations with fall in cardiac output, and it's thought that this is due to an increase in parasympathetic tone and a decrease in heart rate. There's immunomodulating effects, although most of these studies have been done on animals, but there's a decrease in innate immune defenses and an interaction with macrophages. One thing that I frequently learned about were these reactive oxygen species. I didn't know that there was a name for this term, but it's called the Lorraine-Smith effect, and it can actually lead to an ARDS type picture with acute pulmonary hemorrhage and edema. Finally, moving on, I'd like to discuss a little bit more in depth the respiratory effects, because I think it kind of gets brushed over. So there's an increase in intrapulmonary shunt physiology due to this absorption atelectasis. And they did a study where they had healthy volunteers breathe an FiO2 of 1 or 100% oxygen for 25 minutes, and they had doubling of this intrapulmonary shunt physiology in their lungs just by breathing it for 25 minutes. So I spent some time trying to figure out what absorption atelectasis was, and I was Googling like PV equals nRT and Dalton's law 5 days ago at 10 p.m. But I found out this, and I'm going to try to explain it a little bit better. So basically, when we're breathing room air, we're breathing in the majority as nitrogen. And nitrogen is an inert gas that's basically contributing to the pressure of the alveoli and the volume. So it's keeping the alveoli open to provide adequate gas exchange with the oxygen and CO2. When we increase the FiO2, we displace the nitrogen. So that leads to this gradient of alveolar oxygen and the capillary oxygen. There's increased absorption of the alveoli oxygen and a decrease in pressure in the alveoli itself, leading to a decrease in volume and ultimately partial collapse of the alveoli. So that leads us to intrapulmonary shunt physiology, leading to worsening hypoxemia and ultimately hypercapnia. So what do we know so far? And this was officially myth-busted by our fabulous Dr. Rahman in May 2018 about oxygen supplementation in acute MI and patients who are non-hypoxemic. So the two trials that I'd really like to highlight are the DETOX AMI-2 trial. So the DETOX AMI-2 looked at patients who had both NSTEMIs and STEMIs and came in and were not hypoxemic. Their cutoff was an SpO2 of 90%. And it was a randomized controlled trial, so patients either received 6 liters of oxygen for 12 hours or no oxygen. And then their primary endpoints were mortality at 1 year, rehospitalization for MI, and mortality at 30 days. And they found no differences between the groups. So at least in this study, there was no benefit to oxygen therapy in non-hypoxemic patients. The AVOID trial looked at actual STEMIs and diagnosed STEMIs. And based on kind of the mechanisms that I discussed previously on coronary vasoconstriction, whether actual oxygen supplementation in patients was contributing to myocardial infarct size. Their primary endpoints were myocardial infarct size, and then their secondary was 6-month follow-up in terms of rehospitalization for MI, size of infarct at 6 months based on cardiac resonance imaging, and cardiac arrhythmias. And they found statistically significant evidence in all of their secondary endpoints. So it looked like patients who were non-hypoxemic, and their cutoff was 94%, I think, were either given they were given 8 liters, there was some actual harm to providing these patients who were sitting at 94% and above 8 liters of oxygen in terms of their cardiac infarct size. So there's a lot of studies on oxygen supplementation in acute stroke and ischemic brain injury. There's also studies on hyperoxia and traumatic brain injury. I think for the purposes of this talk, we're going to stick with acute stroke and ischemic brain injury. So the study that I'd like to highlight here was a randomized controlled trial of, I think, 8,000 patients in England. And it randomized patients who were either presenting for an ischemic or hemorrhagic stroke acutely, and they were given 72 hours of at least 3 liters of nasal cannula versus nocturnal oxygen at 3 liters versus intermittent oxygen as needed for an SpO2 of 93%. Their criteria then, in terms of their endpoints, was the modified Rankin criteria, which was looked at 90 days post-acute event. And so this criteria looks at everything from mortality to disability, and they found no differences between any of the groups. So there was no benefit to this group of patients either. So moving on to kind of everybody else. So I really couldn't read or find literature without them really referencing this graph and this kind of U-shaped relationship between PaO2 and mortality. And it was first described in Critical Care Medicine in 2008 by De Jong. And it was a retrospective study of 36,000 patients in the Netherlands, and they were all mechanically ventilated, medical and surgical patients. And basically they found that a high PaO2 and a low PaO2 was associated with after 24 hours of ventilation, was associated with an inpatient mortality, statistically significant. And their cutoffs, so they're like funny and European, they're in kilopascals, but their cutoffs were actually like a PaO2 of less than 66.5 and a PaO2 of 123, or a kilopascal of 16.9. So this kind of, I think, makes sense in terms of this part of the graph, because if you're 24 hours into being ventilated and you still have a pretty low PaO2, you probably have had a pretty, significant hypoxemic event and are suffering from pretty severe disease. But there was pretty compelling evidence here that even a PaO2 of 123 and higher was associated with an increased mortality in patient. So that brings us to the Hyper-2S trial, which is a trial done in France. It was a multi-center 2x2 factorial design, randomized controlled trial that wanted to look at hyperoxia and hypertonic saline for resuscitation in patients with septic shock. All these patients were admitted for septic shock and on vasopressor support. They were all mechanically ventilated. Their primary endpoint was mortality at 28 days, although they looked at a number of other secondary endpoints. And the way that they split the patients up was either based on normoxia, so they titrated the ventilated patients to an arterial oxygen based on the ABG of 88 to 95% for the first 24 hours, versus ventilated patients that were just put on an FiO2 of 1 for 24 hours, and then were switched over to the normoxia group. So this trial was stopped prematurely because there was an increase in amount of serious adverse events in the hyperoxia group, and there was also a non-statistically significant increase in the amount of mortality in the hyperoxia group as well. There was no difference either when they controlled for whether the patients received hypertonic saline or normal saline for resuscitation. So this paper really went into, describe this even further. So this was a single-site study in Italy that looked at the effect of conservative versus conventional oxygen therapy on mortality. It was a really nicely designed study. The patient inclusion criteria was a 72-hour ICU stay. They did not have to be intubated. And the primary endpoints were mortality, and then they also had a number of secondary endpoints, which I will show you. Okay. So the types of patients, these are both medical and surgical ICU patients, and their methods were they titrated to a lowest possible FiO2 based on an ABG. So this was a PaO2 of 70 to 100. And then the arterial oxygen was titrated between 94 to 98, with up titration if the arterial oxygen dropped below 94%. And this was based on 1 ABG per day. The conventional was based on an FiO2 of at least 0.4, ventilated or not, and they said in their methods that they used other, nasal cannula and high flow oxygen to maintain this. And then a PaO2 of up to 150 with arterial oxygen sats of 97 to 100%, with up titration to greater if the patient fell below 97%. So they found pretty remarkable results, I think. So there was statistically significant differences in ICU mortality between the conventional versus conservative patients, and overall hospital mortality, new development of shock, bacteremia, and mechanical ventilation-free hours. And actually it was really interesting. So the PaO2 differences were not that great between the two groups. So the PaO2 in the conservative group was between 70 to 100, and it said the median, I think, was 83, whereas the median for the conventional group, because they were trying to titrate below 150, was like 110. So it wasn't a huge difference. So the probability of survival so this is the conservative oxygen group, was much higher even at 60 days post randomization and inclusion in the trial. So that leads us to a big meta-analysis and systematic review that was done and published in The Lancet in 2018 that include all of the studies that I've talked about previously and some other ones. So it ultimately included 25 randomized controlled trials, including stroke, MI, critical illness, septic shock, and they designated the treatment arm as either any FiO2 or PaO2 that was targeting some sort of liberal oxygen therapy versus a conservative approach. This was their forest plot. So they found a statistically significant association with in-hospital mortality overall, and relative risk of 1.21, a 30-day mortality overall of 1.14, and mortality at longest follow-up overall of 1.1. And they claimed for every 1% increase in SpO2 greater than 96%, there was a relative risk of inpatient and hospital mortality of 25%. And for every 1% increase of 96% at longest follow-up, there was a relative increase in mortality of 17%. So this is pretty compelling evidence in terms of how we're titrating oxygen for patients in the hospital, and that it could be associated with effect on short-term and long-term mortality. So where do we go from here? The British Medical Journal late last year, published rapid recommendations regarding oxygen therapy for acutely ill patients. So anyone anyone receiving oxygen therapy, and they had strong recommendations that oxygen therapy should not be titrated higher than 96%, and that we should not even start patients on oxygen therapy at or below 93%. At and above 93%. We suggest also not starting strong therapy between 90 to 92%, and this was a weak recommendation. So, of course, this applies to patients receiving oxygen therapy. It doesn't apply to patients who would possibly need a high FiO2, so those suffering from carbon monoxide poisoning or decompression illness. So, based on a number of these studies, I think there are overall hospital and cultural norms to leaving patients on oxygen supplementation despite their O2 sats being greater than 96%. I think the problem with this is we don't know what their actual dissolved PaO2 is when that's happening. We'd know it if we got an ABG, but we don't know what that's actually correlating to. And there's been numerous studies that this overall could lead to an increase in inpatient mortality. With that, just want to thank Dr. Freed and Dr. Ashamala and Jessica Reeves, the librarian, and then these are my references. So happy to take any questions.
Before we vote, any discussion? Unfortunately, we don't have any microphones to pass around, so if you do have a comment or criticism, please speak loudly so they can pick it up on the video.
No one has accused me of not speaking loudly. Did you come upon any information about hyperbaric oxygen? I've been very skeptical about the use of hyperbaric oxygen for patients who have adequate saturations, and they're being told this will help your wound heal better. And I'm wondering all of the negative sides of hyperbaric oxygen, supersaturating them with oxygen.
So I didn't specifically read any papers on that, but there were comments in terms of reviews, and I think that's more of the surgical literature. No, I didn't specifically look at that, but there were comments and sort of reviews of hyperoxia on whether this was actually helpful in wound healing, but I'm not personally sure. Yeah.
Oxygen is routinely given to patients undergoing surgery who have perfectly normal lungs and are often breathing normally on their own. Has that been looked at? Is that potentially harmful rather than beneficial for adding to the safety margin?
Mm-hmm. Yeah, so one thing that I did come across was this kind of safe time apnea that patients get pre-intubation for surgery with anesthesia, where they're given a very high FiO2 kind of to stop or as a safety measure before their SpO2 drops. They noticed in those studies too that they have, unless they have CPAP, they get intrapulmonary shunt physiology, but the CPAP that they provide prevents kind of that intrapulmonary shunt physiology and kind of keeps the alveoli open. I haven't spent very much time in the ORs lately. I'm not quite sure how they're titrating patients who are ventilated in the ORs, but I'm sure that would be an important to look at, yeah.
So are there any other comments before we vote? Okay, so is it a myth in acutely ill patients targeting an SpO2 greater than 96% is harmless. How many think this is true? How many think it's possible? How many think this myth is busted? All right. Great job.